Welcome, future caregivers, critical thinkers, and healers. Ever feel like you're maybe drowning in information, especially when you're starting a journey as vital as nursing? Well, you're definitely in the right place because today we're throwing you a lifeline. Today we're doing a special deep dive, really tailor-made for you, our prospective nursing students. We've gathered an essential stack of foundational knowledge, from mastering patient safety and communication. Our mission, well, it's to equip you with the fundamental insights that will truly be the bedrock of your practice.
Indeed. Think of this as your essential pre-flight briefing, if you will, for what is a challenging but incredibly rewarding career. We'll unpack the core principles that guide every single nurse, connecting the dots between the theory and the real-world scenarios you're going to face. What's really fascinating here, I think, is how early exposure to these concepts builds such a robust framework for your future learning and, importantly, your clinical reasoning. You'll gain a holistic understanding of how these seemingly separate concepts actually intertwine to ensure effective, compassionate, and of course, safe patient care.
Because these aren't just textbook chapters, right?
Mm-hmm.
These are the skills and knowledge you'll use every single day to save lives, prevent illness, bring comfort. These are really the building blocks that will empower your patients, protect them, help them heal. Understanding this whole approach from day one really sets you up for success. Okay, let's unpack this. First up, let's talk about something you'll be battling constantly as a nurse. Infection. Imagine this. A tiny, invisible army is always trying to breach our body's defenses. As a nurse, you are humanity's first line of defense in that battle. So how do we equip you for this fight? Let's start by understanding our enemy, infection itself.
Right. And infection isn't just a single germ. It's more like a sequence, a chain of events, really. There are 6 crucial steps or links in this chain. For an infection to actually take hold, every single link in this chain must be present and intact. Now, the real insight for you as future nurses, every one of those steps is a potential breaking point, a place you can intervene to stop the spread. Your role will involve using various infection control practices, things like medical asepsis, surgical asepsis, standard precautions specifically to break that chain. Halt the spread. It's proactive. It's fundamental.
So when we talk about these invisible threats, what exactly are we facing? What are the main types of pathogens a nurse is likely to encounter? And what makes each one uniquely challenging?
That's a great question because, we're not just dealing with one kind of invader. You'll encounter bacteria, which are these single-celled organisms. Some are harmless, but others cause infections you probably know, like staph or strep throat. Then there are viruses. These are even tinier organisms that basically hijack your body's own cells to reproduce themselves. Think the common cold, flu, or more serious ones like HIV or hepatitis. We also have fungi, which include molds and yeasts. Things like candida infections, yeast infections, athlete's foot, those are fungal. Then there's a really tricky type called prions. These aren't even technically alive. They're just misfolded proteins that cause other proteins to misfold. It's like a chain reaction of corruption in your body's building blocks.
Wow, that sounds difficult.
They are. Very rare, thankfully. But diseases like 𝘚𝗏𝗏𝗏 disease, caused by prions, currently have no treatments. And finally, we have parasites. These range from microscopic protozoa, like the ones that cause malaria, to larger organisms like worms or flukes. It's also important to understand a term called virulence. That's simply a pathogen's ability to invade and injure a host. Basically, how strong or aggressive it is.
That's quite the rogues gallery. Okay, to make this a bit more concrete, let's take one example. Herpes zoster, or shingles. It's a pretty common viral infection, and it really shows how these pathogens can kind of play the long game, right?
Exactly. It erupts, often years after someone has had chickenpox. It reactivates from a dormant state, usually when the immune system is under stress or compromised. What's interesting here is that shingles often has what we call a prodromal period. Days before the visible rash appears, the patient might feel pain, tingling, or burning along a specific nerve pathway. That's a subtle clue you'll learn to recognize.
So what makes someone more likely to get shingles?
Good question. Risk factors often include having another illness at the same time, significant stress, a compromised immune system, maybe from medications or another condition fatigue, poor nutrition, or just being an older adult. Their immune function tends to decline naturally with age. When you assess a patient with shingles, you'll typically see a very distinctive rash, usually only on one side of the body, following that nerve path. It might look like little blisters first, then maybe pustular, then crusting over. Your nursing care focuses on assessing and managing their pain, monitoring the lesions, checking for fever or any neurological complications, and critically, preventing its spread.
Preventing spread. Why is that so important with shingles?
Because someone who hasn't had chickenpox before or who has a weakened immune system could actually contract chickenpox from contact with the shingles lesions. So isolation and careful wound care are key.
Got it. It's a really clear example of how a virus can just wait.
And then reactivate when the body's defenses are down. Yes.
Now, your body isn't just sitting there waiting to be invaded, thankfully. It has its own incredible defenses, its own bouncers. How does our body fight back?
Precisely. We have two main types of immunity, and they work together. First, there's nonspecific innate immunity, sometimes called native immunity. This is your body's immediate general response to any foreign organism that tries to get in. Think of it as your body's first responders, the general patrol force. It doesn't need to have seen the invader before.
Like our skin.
Exactly. Your intact skin is an amazing first line of defense, like a fortress wall. But also things like mucous membranes, various secretions, enzymes, and specialized cells called phagocytes. They're like little Pac-Men that engulf invaders. This innate system also quickly activates inflammation, which helps to localize the invasion and prevent it from spreading further. It's fast, it's broad spectrum, but it's temporary and doesn't remember the specific threat.
Okay, so that's the immediate kind of brute force defense. What's the other type, the more specialized one?
That's specific adaptive immunity. This is where your body learns and remembers specific invaders. It takes a bit longer to kick in initially, but it creates highly specific weapons called antibodies. Think of them like tiny targeted missiles designed specifically for that identifiable foreign organism or antigen. This system provides more permanent immunity. It involves specialized immune cells, B lymphocytes and T lymphocytes to produce those specific antibodies.
So this is the system that vaccines work with.
Precisely. Vaccines essentially train this adaptive immune system, giving your body a memory of a specific pathogen without causing the disease, so it can mount a quick targeted defense if it encounters the real thing later. Now let's connect the dots back to that chain of infection we mentioned. Let's think like detectives here. Every single link in the chain of infection is a point where you, the nurse, can intervene.
Right, the 6 links. Agent, reservoir, portal of exit, mode of transmission, portal of entry, and a susceptible host. It really does sound like detective work. Breaking any one of those links is our nursing superpower, you could say. Which link do you think new nurses focus on most often, or maybe where they can have the biggest impact early on?
That's a fantastic question. Often it's the mode of transmission in the portal of exit entry. Think about it, simple things like diligent hand hygiene and using personal protective equipment, or PPE, correctly. They seem basic, maybe even mundane sometimes, but they're absolute superheroes in infection control. They break the chain right there.
Let's quickly walk through those 6 links again, just to solidify it.
Sure. First, the causative agent, the actual pathogen, bacteria, virus, fungus, prion, parasite. Second, the reservoir, where that pathogen lives and multiplies. Could be a person, an animal, water, soil, even insects. Third, the portal of exit, how the pathogen gets out of the reservoir or host. Respiratory tract, coughing or sneezing. GI tract, urinary tract, skin lesions, blood, body fluids. Lots of ways. Fourth, the mode of transmission, how it travels from the reservoir to a potential new host. This is often through contact, direct person-to-person touch, or indirect touch via a contaminated object, or droplet transmission, like from sneezing within a few feet, or airborne, smaller particles that hang in the air, or vector-borne via an animal or insect like a tick or mosquito. Fifth, the portal of entry, how the pathogen gets into the new host. Often it's the same route as the portal of exit, respiratory tract, broken skin, etc. And sixth, the susceptible host, an individual whose defenses are down for some reason, making them vulnerable to infection. Immunocompromised, breaks in the skin, very young, very old.
Got it. So knowing that chain is key to prevention. Now, an infection isn't just an instant thing, right? It progresses through stages. Knowing these helps you anticipate symptoms and intervene effectively.
Absolutely. It's a process. It starts with the incubation period. This is the time from when the pathogen first enters the body until the very first symptom appears. The person might feel fine, but the pathogen is setting up shop. Then comes the prodromal stage. This is when you might start feeling generally unwell, maybe a bit tired, achy, just off. The symptoms are vague, not specific yet, but the pathogen is actively multiplying.
Oh, I think I might be coming down with something stage.
Exactly. Then you move into the illness stage. This is when the characteristic symptoms specific to that particular infection become obvious. Sore throat for strep, the rash for measles, etc. And finally, there's convalescence. This is when the acute symptoms start to disappear and your body begins to repair and recover. Total recovery, though, can sometimes take days, weeks, or even months, depending on the illness in the person.
Okay, that timeline is helpful. So who's most at risk? Who are these susceptible hosts we need to be extra vigilant about?
This is where your assessment skills really come in, because risk factors vary. But some common ones include inadequate hand hygiene by the client or caregivers. That's a big one. Anyone with compromised health or weakened defenses is obviously at higher risk. Think people who are immunocompromised, maybe post-surgery, those with indwelling devices like catheters or IV lines, anyone with breaks in their skin. Also, poor oxygenation, impaired circulation, chronic diseases like diabetes or kidney failure, these all increase susceptibility.
What about factors related to the care environment or lifestyle?
Definitely. Caregivers not following proper asepsis standards is a risk. Poor personal hygiene or nutrition in the client, smoking, excessive alcohol use, high stress levels, these can weaken defenses. Crowded living environments can facilitate spread, and things like IV drug use with shared needles or unprotected sex obviously increase risk for specific types of infections.
And you mentioned older adults are a particularly high-risk group. Can you elaborate on why that is?
Yes, it's really important to understand the changes with aging. Older adults often have a slowed or less intense inflammatory and immune response. This means they might have a pretty advanced infection before you see the typical signs like a high fever. Instead, you might see confusion, agitation, or maybe new incontinence as the primary sign.
That's crucial to know.
It is. They also tend to have thinner skin, which is a less effective barrier, decreased blood flow, which slows wound healing, and sometimes decreased cough or gag reflexes, increasing aspiration risk. Add in common chronic illnesses, potentially decreased mobility, sometimes dementia affecting self-care, and they often have more invasive devices. All these factors contribute to their increased susceptibility. It really demands careful, individualized assessment. And speaking of risk, there's a specific category of infections we need to talk about, healthcare-associated infections, or HAIs. These are particularly important for you to understand because preventing them is a core nursing responsibility.
Right. These used to be called nosocomial infections. They're infections a client gets while receiving care in a healthcare setting.
Exactly. They can come from an external source, say, contaminated equipment, or another patient, which we call exogenous. Or they can arise from the client's own body. Maybe their normal bacteria get into the wrong place or overgrow when their defenses are down. That's endogenous. HAIs are a serious problem, often seen in high-risk areas like the ICU, but they can happen anywhere. And the single most effective way to prevent them?
Hand hygiene.
Frequent and effective hand hygiene. It cannot be stressed enough. The most common site for HAIs is actually the urinary tract, often linked to catheter use and commonly caused by bacteria like E. coli or Staphylococcus aureus. Other common sites are surgical wounds, the respiratory tract, and the bloodstream. It's also worth knowing the term iatrogenic infection. That's a specific type of HAI resulting directly from a diagnostic or therapeutic procedure, like an infection from an IV line insertion. Your job as a nurse is to stay current with evidence-based practice guidelines to actively prevent these infections, especially those caused by tricky multi-drug-resistant organisms.
Okay, so we know the risks, we know the types of infections. How do we spot them? As a nurse, you become a keen observer, right? Looking for those generalized or systemic infection symptoms.
That's right. You're looking for things like fever, chills, especially when the temperature is rising in diaphoresis, or sweating, particularly when the temperature starts to decrease. You'll often notice an increased pulse and respiratory rate. The body works harder when fighting infection and fever. Patients often report feeling generally unwell, or malaise, fatigue, loss of appetite, maybe nausea or vomiting, abdominal cramping or diarrhea. Enlarged lymph nodes are another common sign.
And remembering what you said about older adults.
Yes, remember for older adults, the signs might be less typical. Sudden agitation, confusion, or new incontinence could be the first indicators rather than a classic fever. Beyond these systemic signs, you'll also look for signs of inflammation, which is the body's local response to injury or infection.
Redness, warmth.
Exactly. Redness due to dilated blood vessels, warmth in the area, edema or swelling, pain or tenderness, and sometimes a temporary loss of function of that body part. As inflammation progresses, you might see exudate, that's fluid containing dead tissue cells and white blood cells. It might be serous, clear, sanguineous, bloody, or purulent containing pus.
Okay, so we rely on our assessment skills, but lab tests and diagnostics are also crucial pieces of the puzzle, right? What key results point towards infection?
Absolutely. Lab results often confirm your suspicions. You'll look for leukocytosis, which is an elevated white blood cell count typically over 10,000 per microliter. You might also see an increase in specific types of white blood cells on the differential count, sometimes called a Lesch shift, indicating the body is churning out immature neutrophils to fight bacteria. An elevated erythrocyte sedimentation rate, or ESR, is another indicator of inflammation somewhere in the body. It should usually be less than 20 millimeters per hour. And of course, the most definitive sign is the presence of the specific microorganism on a culture taken from the suspected site, like urine, blood, sputum, or wound drainage. Diagnostic procedures like X-rays, CT scans, or biopsies might also be used to pinpoint the location of an infection or abscess.
This is where your training truly shines. You're not just observing, you're actively preventing and treating. Let's talk about the nurse's arsenal, interventions to control infection.
Right. Your interventions are key, starting with the basics. Frequent and effective hand hygiene. Before touching a patient, after touching a patient, after touching their surroundings, before procedures, it's constant. Client education is huge. Teaching about recommended immunizations, especially for vulnerable groups. Teaching good oral hygiene, which actually decreases the growth of microorganisms in the mouth. Encouraging adequate fluid intake is important too. It helps prevent urinary stasis, flushes the urinary tract, and maintains good skin hydration and integrity. For clients who are immobile, pulmonary hygiene is critical. Things like turning them regularly, encouraging coughing and deep breathing, using an incentive spirometer. This prevents respiratory secretions from pooling and leading to pneumonia.
And PP.
Absolutely. Consistent use of aseptic technique and proper personal protective equipment. Gloves, masks, gowns, eye protection tailored to the situation and potential exposure risk. This applies to all clients because you never know. And we also need to practice and teach good respiratory hygiene and cough etiquette, covering coughs and sneezes, using tissues and disposing of them properly, wearing a mask if you're coughing, maintaining distance, and performing hand hygiene. Simple, but effective. Beyond these universal measures, we have specific isolation guidelines. These are designed to reduce the transmission of known or suspected infectious organisms. They apply when contact with potentially infectious material is anticipated based on the specific pathogen and its mode of transmission. Remember to change PPE after contact with each client, and even between procedures on the same client if there's heavy contamination.
And the psychosocial impact of isolation is important too, right?
Very important. Being in isolation can be lonely and frightening. Patients are at higher risk for depression and loneliness. Part of your job is to help the client and their family understand why isolation is necessary, communicate clearly, and provide sensory stimulation to combat the isolation.
Okay, let's quickly recap those tiers of precautions. They guide so much of what nurses do daily.
Right. Tier 1 is standard precautions. Think of this as the baseline, the minimum infection prevention practices applied to all patient care, regardless of their diagnosis or presumed infection status. It means treating all blood, body fluids, except sweat, non-intact skin, and mucous membranes as potentially infectious. So, rigorous hand hygiene, using gloves appropriately, masks, eye protection gowns if splashing or spraying is likely. Proper handling of soiled items and sharp safety are also key parts.
And then Tier 2 for specific situations.
Exactly. Tier 2 is transmission-based precautions. These are used in addition to standard precautions for patients with known or suspected infections that spread in specific ways. There are three main categories. Airborne precautions. Used for infections spread by tiny airborne droplet nuclei, smaller than 5 microns, like measles, varicella, chickenpox, or tuberculosis. These require a private room with special negative pressure airflow and for healthcare workers to wear a fitted N95 respirator mask. Droplet precautions. Used for infections spread by larger droplets, greater than 5 microns, that travel short distances, like 3 to 6 feet, such as influenza, rubella, pertussis, or bacterial meningitis. These require a private room or cohorting with someone with the same infection, and a regular surgical mask for providers and visitors within close proximity. And contact precautions. Used for infections spread by direct contact with the patient or indirect contact with contaminated items in their environment. Think MRSA, VRE, C. difficile, RSV, or scabies. These require a private room, or cohorting, and gloves and gowns for caregivers and visitors. Equipment should ideally be dedicated to that patient or thoroughly cleaned between patients.
Okay, that's clear. Beyond these physical barriers and hygiene, medications are obviously a key part of the fight.
Indeed. We use antipyretics like acetaminophen or ibuprofen to manage fever and discomfort. Your job includes monitoring their effectiveness and tracking temperature changes. Then there's antimicrobial therapy. This includes antibiotics for bacteria, antivirals, antifungals, and antiparasitics. Your role is to administer these exactly as prescribed, Monitor for effectiveness, looking for reduced fever, improved symptoms, decreasing white blood cell count, and, critically, maintain the prescribed schedule to ensure consistent therapeutic blood levels.
And you mentioned multi-drug-resistant infections earlier. That requires special consideration.
It absolutely does. Multi-drug-resistant infections, or MDRIs, like MRSA or VRE, are caused by pathogens that have adapted and become resistant to many common antibiotics. This seriously limits treatment options. This is why obtaining culture and sensitivity specimens before starting antimicrobial therapy is so vital whenever possible. It helps ensure we're using an antibiotic the bug is actually susceptible to. You'll also monitor antimicrobial drug levels in the blood sometimes to ensure they're in the therapeutic range but not toxic. And patient education is key here, emphasizing the importance of completing the full course of therapy even if they feel better, and avoiding unnecessary antibiotic use, which contributes to the development of resistance.
Finally, let's touch on reporting communicable diseases. This is a legal and ethical responsibility for nurses. Why is it so important?
It's vital for public health. Reporting ensures appropriate medical treatment for the individual, like with tuberculosis contact tracing. It helps public health officials monitor for common source outbreaks, like a foodborne illness. It allows for planning and evaluating control and prevention strategies, such as immunization campaigns based on disease trends. It helps identify outbreaks at epidemics quickly, and ultimately, it helps determine public health priorities and allocate resources effectively. You, as a nurse, are a critical link in this surveillance system. Now let's zoom out a bit. All these actions you take as a nurse, from assessing that shingles rash to administering antibiotics to implementing isolation precautions, they all fit into a larger, powerful framework. The nursing process. This is how you think, how you plan, and how you act as a nurse. It's your blueprint for providing care.
So what exactly does a nurse do? It's clearly much more than just following orders.
Absolutely. Nurses contribute fundamentally to improving patient health by applying this nursing process to develop patient-centered plans of care. Nursing practice itself, as defined by the American Association of Colleges of Nursing, AACN, isn't just direct hands-on care. It's any nursing intervention that influences healthcare outcomes, including managing care, administration, education, research, even policy development.
And nurses wear many hats, don't they?
So many. You are a caregiver, certainly, but also a communicator, an educator, a counselor, a leader, a researcher, an advocate for your patients, and a collaborator working with the entire healthcare team. In these foundational stages of your education, you'll really focus heavily on the role of the nurse as a caregiver, promoting health, preventing illness, restoring health when possible, and helping patients cope with illness or end of life. And equally important, the nurse as an educator, empowering patients with knowledge about their health. All of this ties into providing holistic care. That means looking at the whole person, their physical, mental, emotional, social, and spiritual needs, not just their disease or injury. That holistic perspective is essential to nursing.
To provide that holistic care, you first need a solid understanding of some core concepts: health, wellness, and illness. They might seem simple, but how do we define them in a healthcare context?
Good point. The World Health Organization offered a great definition of health way back in 1974, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So it's much more than just not being sick. Wellness builds on that. It's an active state of being healthy by intentionally living a lifestyle that promotes good physical, mental, and emotional health. It's about proactive choices. Illness, on the other hand, is the unique personal response of a person to a disease. It's an abnormal process involving a changed level of functioning compared to their baseline.
And diseases themselves can have many causes.
Many causes. Biological agents like bacteria or viruses, toxins, developmental problems, issues with body secretions, genetic anomalies, physical agents like burns or radiation, even physiological or emotional reactions to stress can all cause disease. It's also really vital to distinguish between acute and chronic illness. An acute illness typically has a rapid onset, is relatively short-term, and is often reversible with treatment. Think of the common cold or appendicitis. Usually no long-term consequences if treated properly. A chronic illness, however, usually has a slower onset, lasts for a long time, often lifelong, and involves irreversible changes in anatomy or physiology. Think arthritis, diabetes, heart failure. It requires long-term management and care, and patients often experience periods of remission and exacerbation, or flare-ups. This distinction dramatically shapes how you approach patient care and education.
Thinking about health choices and behaviors, there's a model that helps us understand why patients make the decisions they do about their health. This seems huge for patient education. Can you tell us about the health belief model?
Yes, this is a really useful framework. The health belief model, suggests that a person's health-related behavior depends on several factors. First, their perceived susceptibility. Do they believe they are actually at risk for the disease? Second, their perceived severity. If they did get it, how serious do they think it would be? Third, the perceived benefits of taking action. Do they believe the recommended action, like getting a vaccine or changing diet, will actually help? Fourth, the perceived barriers. What do they see as the obstacles to taking action? Cost, side effects, inconvenience, fear.
So it weighs the pros and cons, essentially.
Kind of, yes. It also considers cues to action, things that might trigger them to act, like a health screening reminder or a friend getting sick. And finally, there's self-efficacy, their confidence in their own ability to successfully perform the action. Understanding where your patient stands on these beliefs helps you tailor your education and support much more effectively. You can address their specific concerns and barriers.
Building on that idea of influencing factors, we also need to consider risk factors and the concept of health disparities.
Right. Risk factors are simply influences that increase a person's likelihood of developing an illness or injury. We often categorize them as modifiable things that can be changed, like smoking, diet, exercise habits, lifestyle choices, and non-modifiable things that cannot be changed, such as age, genetic makeup, or family history. Identifying these helps target prevention strategies. Then there's health disparity. Healthy People 2010 define this as a particular type of health difference that is closely linked with social, economic, and environmental disadvantage.
So differences in health outcomes based on things like race, ethnicity, income, location.
Exactly. These disparities often stem from unequal access to resources like quality healthcare, nutritious food, safe housing, or education. Recognizing these systemic issues is crucial for advocating for health equity and tailoring care to overcome barriers faced by disadvantaged populations. Some disparities might be modifiable through policy or community action, while others reflect deeper systemic issues. Now, as a nurse, you'll be involved in preventing illness and promoting health at different stages. We talk about 3 levels of preventive care. You'll guide patients through all of these across their health journey.
Okay, let's break those down. What's the first level?
Primary prevention. This is all about promoting health and preventing disease processes or injuries before they even start.
Like immunizations, or teaching about healthy diets and exercise.
Precisely. Health education, promoting seatbelt use, banning hazardous products. These are all primary prevention efforts aimed at the whole population or those at risk.
Okay, then what's secondary prevention?
Secondary prevention focuses on early detection of disease, prompt diagnosis, and swift treatment to halt or slow its progression. The goal is to catch things early when they're most treatable.
So screenings like mammograms, blood pressure checks, colonoscopies.
Exactly. Also recommending regular medical and dental checkups. These activities aim to identify disease in its earliest, asymptomatic stages.
And the third level?
Tertiary prevention. This begins after an illness or injury is diagnosed and treated. The goal here is to reduce disability, help rehabilitate patients to their maximum possible level of functioning, and prevent complications or recurrence.
So physical therapy after a stroke, cardiac rehab after a heart attack, chronic disease management programs for diabetes.
Yes, all examples of tertiary prevention. You're helping patients live well with their condition and minimize its long-term impact. Nurses play vital roles at all 3 levels. Now, how do nurses actually think through all of this complex patient information and decide what to do? This brings us to the concepts of clinical reasoning and the overarching framework of the nursing process. Clinical reasoning is the mental process nurses use to think critically in clinical situations, analyzing data, understanding the patient situation, considering different possibilities, and deciding on a course of action. Clinical judgment is the outcome or the decision that results from that reasoning process.
And this is a skill that develops over time, right? Like Patricia Benner's model describes nurses moving from novice to expert.
Exactly. Your ability to reason clinically grows with experience and knowledge. The nursing process provides the systematic structure for applying that reasoning. It's often remembered by the acronym ADPIE.
ADPIE: assessment, diagnosis, planning, implementation, and evaluation.
That's it. It's a systematic, dynamic, ongoing cycle. It's interpersonal, involving the patient and family. It's outcome-oriented, focused on achieving specific patient goals, and it's universally applicable to all nursing situations. Its ultimate goal is to develop truly individualized nursing care plans.
Okay, let's break down each step. Step 1, assessment. This seems like the foundation.
It absolutely is. Assessment is the systematic and continuous collection, analysis, validation, and communication of patient data. You're gathering information to determine the patient's current health status, identify their needs for nursing care, and establish a complete database.
And this data comes in different forms.
Right. We talk about objective data, also called signs. These are things that are observable and measurable by the nurse, like a temperature reading, the act of vomiting, a respiratory rate of 28, a visibly reddened throat. Then there's subjective data, or symptoms. This is information perceived only by the affected person, what the patient tells you. Feeling dizzy, itchy, having a sore throat, saying they can't sleep because of coughing.
Where do you get all this data?
From multiple sources. The patient is usually the primary source, but family members can provide valuable information too, especially if the patient can't communicate well. The patient record, your own physical assessment findings, lab reports, diagnostic test results, medical history, notes from other healthcare providers, consultations, even the nursing literature, all contribute to the database. Data validation is a crucial part of assessment. You need to double-check information, especially if there are inconsistencies, like if a patient says their stomach feels fine, but their abdomen is visibly swollen and you hear hyperactive bowel sounds. You need to investigate discrepancies.
And once you have all this data,
you start clustering it. You group related pieces of information together into patterns. This helps you begin to see the bigger picture and identify potential health problems or strengths. And of course, documentation is essential. You need to record your findings accurately and concisely, often using the patient's own words for subjective data, while avoiding judgmental language. Timely reporting of significant changes is also critical.
It's important to note, too, that while RNs can delegate certain data collection tasks, like taking vital signs, to LPNs or unlicensed assistive personnel, UAPs, the RN always retains accountability for the overall assessment, interpretation of data, and subsequent decisions.
Absolutely. Comprehensive assessments, interpreting findings, critical decision-making, those remain RN responsibilities.
Okay, step 2, diagnosis. After collecting all that data, what happens next?
Diagnosis involves analyzing the patient data you've collected to identify a patient's strengths and, critically, their health problems that nurses can address. It describes patient problems that nurses are licensed and competent to treat independently.
So this is different from a medical diagnosis.
Yes, very different. A medical diagnosis identifies a specific disease process, like pneumonia or diabetes mellitus. The physician directs the primary treatment for the disease itself. A nursing diagnosis, however, describes a patient's response to their health problem or life process, something that nursing interventions can target. Examples might be ineffective airway clearance related to thick secretions secondary to pneumonia, or risk for unstable blood glucose related to insufficient knowledge of diabetes management.
How do you formulate one?
The process involves recognizing significant data points, identifying patterns or clusters in the data, identifying the patient's strengths and problems, and considering potential complications. NANDA International provides a standardized terminology for nursing diagnoses. Often, a nursing diagnosis is stated in a 2-part or 3-part format. For example, problem RT, related to etiology cause, AED, as evidenced by defining characteristics data. So, constipation RT opioid medication. Use AEB, no bowel movement for 3 days, and pregnant report of straining. You also distinguish between actual nursing diagnoses, a problem that currently exists supported by defining characteristics, and risk nursing diagnoses. The patient is vulnerable to developing the problem, but it hasn't happened yet.
And then you need to prioritize these diagnoses.
Yes, prioritization is key. You use frameworks like Maslow's hierarchy of needs, or the ABCs, airway, breathing, circulation. High-priority diagnoses are those that, if untreated, could result in harm to the patient emergent, life-threatening issues. Intermediate priority diagnoses involve non-emergent, non-life-threatening needs, but are still important for health and wellness. Low-priority diagnoses might affect future well-being, but aren't directly related to the current main problem.
Okay, assessment and diagnosis. Next is planning.
Step 3, planning. This involves identifying patient-centered goals and expected outcomes, and then determining the specific nursing interventions needed to achieve those outcomes. Essentially, what do we want to happen, and what are we going to do to help make it happen?
And step 4, implementation.
Right. Implementation is simply carrying out the plan, performing the nursing interventions you decided on during the planning phase, putting the plan into action.
And finally, step 5, evaluation.
Evaluation. This is where you measure the extent to which the patient has achieved the outcomes specified in the planning phase. Did the interventions work? Were the goals met, partially met, not met? Based on this evaluation, you might continue the plan, modify it, or terminate it if the goals have been achieved. It's a continuous cycle. Evaluation often leads right back to reassessment and adjustments to the plan.
Okay, let's shift gears a bit. Every time you walk into a patient's room, one of the first things you'll likely do is assess their vital signs. These numbers aren't just routine checks. They're like the body's storytellers, giving you rapid-fire information about what's going on inside. Learning to read this story is crucial.
Indeed. Vital signs are fundamental clinical measurements. They typically include blood pressure, pulse, heart rate, body temperature, respiratory rate, oxygen saturation, and increasingly pain, which is often called the fifth vital sign. Their purpose is multifold. Provide baseline data on admission, help identify trends or patterns over time, detect changes in condition, and ultimately guide treatment decisions and nursing interventions. And remember, as the RN, you are always accountable for interpreting vital signs, even if the task of measuring them is delegated to a UAP. Reassessment and critical thinking about what the numbers mean are your responsibility.
All right, let's break them down. First up, blood pressure, BP. What exactly is it measuring?
Blood pressure measures the force of the blood circulating against the walls of the arteries. There are two numbers. Systolic BP, the top number, represents the maximum pressure exerted when the heart contracts and pushes blood out. Diastolic BP, the bottom number, is the minimum pressure in the arteries when the heart muscle is relaxed between beats.
And what are the main alterations we look for?
We look for hypertension, which is high blood pressure generally defined as readings consistently above 30/80 mmHg, with different stages based on how high it is. A hypertensive crisis is dangerously high, over 880 near 120 mmHg. Nursing interventions for hypertension focus heavily on lifestyle changes, exercise, stress reduction, low-sodium diet, weight loss, and patient education about antihypertensive medications, including their purpose, side effects, and when to notify their provider. On the flip side, there's hypotension, or low blood pressure. This is typically below 9 or 60 mmHg, though it depends on the individual's baseline.
What are the concerns with low blood pressure?
Hypotension can cause symptoms like dizziness, lightheadedness, nausea, blurred vision, increased pulse rate as the heart tries to compensate, and fatigue. If severe, it can impair blood flow to vital organs. Nursing interventions include encouraging fluid intake, if appropriate, having the patient lie down, supine position unless contraindicated, evaluating their medications for potential causes, and importantly, educating them about fall risks and advising slow position changes, like sitting up slowly before standing.
Okay, next vital sign, pulse. What does this tell us?
The pulse reflects the heartbeat. It's the rhythmic expansion and recoil of arteries as blood is pumped by the heart. You're feeling the pressure wave. The expected range for a resting adult is typically 60 to 100 beats per minute. Many factors influence pulse rate: body position, age, activity level, health conditions, even body temperature. When assessing a pulse, you also note its rhythm, regular or irregular, and strength or amplitude.
How do you grade pulse strength?
It's usually graded on a scale. 0 means absent, no pulse felt. +1 is weak or diminished. +2 is considered normal or brisk. +3 is increased or strong. And +4 is bounding. Very strong, forceful.
And alterations in pulse rate?
Tachycardia is a heart rate faster than 100 beats per minute in an adult. It can be caused by exercise, anxiety, fever, certain medications, caffeine, nicotine, or underlying heart conditions involving electrical abnormalities. Patients might feel a racing sensation or have no symptoms. Bradycardia is a heart rate slower than 60 beats per minute. Sometimes this is normal, especially with very physically fit individuals, but it can also be caused by congenital heart issues, heart failure, damage to the heart muscle, or conditions like hypothyroidism. Symptoms, if present, might include dizziness, fatigue, shortness of breath, chest pain, or confusion. It's also crucial. If you detect an irregular rhythm, dysrhythmia like atrial fibrillation, you should always assess the apical pulse directly over the heart with a stethoscope for a full minute to get the most accurate rate.
Got it. Moving on to body temperature.
Body temperature reflects the balance between the heat the body produces through metabolism and the heat it loses to the environment. The expected range is generally considered 36 degrees to 38 degrees C, or 96.8 degrees area to 100.4 degrees area, with the average often cited as 37 degrees C, or 98.6 degrees Fahrenheit. Temperature varies slightly depending on the time of day, circadian rhythms, age, gender, physical activity, health state, and the surrounding environmental temperature. The site you use for measurement also matters. Rectal temps are typically higher than oral, which are higher than axillary armpit.
And the main alteration here is fever.
Yes, fever, also called pyrexia or hyperthermia, is generally defined as a body temperature above 38 degrees C or 100.4 degrees Fahrenheit. It's most commonly caused by infection, as the body raises its temperature set point to help fight pathogens. It can also occur due to increased metabolism from tissue damage or certain inflammatory conditions.
What symptoms accompany a fever?
Patients might have a flushed face, feel warm or hot to the touch, have diaphoresis, sweating, especially as the fever breaks, tachycardia, increased respiratory rate, shivering as the body tries to generate heat, headache, loss of appetite, thirst, muscle aches, fatigue, and general malaise. In young children, high fevers can sometimes trigger febrile seizures. In older adults, confusion or delirium might be the primary sign.
What are the nursing interventions for fever?
If the fever is significantly high, often over 101 degrees 𝘱𝘂𝑡𝑟 per facility policy, and causing discomfort, interventions include encouraging cool fluids, removing excess clothing or blankets, administering antipyretic medications like acetaminophen or ibuprofen. Remember to avoid aspirin in children due to the risk of Reye syndrome. Treating the underlying cause if it's an infection, antibiotics, antivirals, providing a cooler environment, or perhaps using a tepid bath or cooling blanket in more severe cases.
Okay. Next, respiratory rate.
Respiratory rate is the number of breaths a person takes per minute. One breath consists of one inhalation, inspiration, taking air in, and one exhalation, expiration, breathing air out. The expected range for a resting adult is typically 12 to 20 breaths per minute. You assess not just the rate, but also the depth, shallow, normal, deep, and rhythm, regular or irregular, of breathing.
What are the alterations?
Tachypnea is rapid breathing, a rate greater than 20 breaths per minute. It can be caused by physical activity, anxiety, pain, fever, or respiratory conditions like asthma or pneumonia. Symptoms might include dizziness or tingling in the hands if it leads to hyperventilation. Bradypnea is slow breathing, a rate less than 12 breaths per minute. This can be caused by certain health conditions or commonly by medications like opioids or sedatives that depress the respiratory center in the brain. Symptoms might include dizziness, fatigue, weakness, confusion, or impaired coordination due to inadequate oxygenation.
And finally, oxygen saturation, SpO2. This seems particularly important for respiratory status.
It is. SpO2, often measured with a pulse oximeter clipped onto a finger or earlobe, gives an estimated amount of oxygen bound to hemoglobin in the red blood cells. It's expressed as a percentage and provides a quick, non-invasive look at how well oxygen is being carried in the blood, directly reflecting respiratory status. The expected range is generally 95% to 100%.
What happens if it drops below that?
A decreased SpO2, below 95% or sometimes below 90-92%, depending on the patient's condition and facility policy, indicates hypoxemia or low oxygen levels in the blood. This can be caused by various health conditions affecting the lungs or heart, like pneumonia, chronic lung disease, COPD, emphysema, pulmonary edema, or poor cardiac output. Symptoms often include decreased mental alertness, restlessness, anxiety, or confusion as the brain isn't getting enough oxygen.
So how often should vital signs be taken?
There's no single answer. The frequency depends entirely on the patient's condition, their acuity level, medical diagnosis, any comorbidities, the medications they're receiving, and any therapies or treatments they're undergoing. It could be every 15 minutes in a critical situation, every 4 hours on a stable medical floor, or just once a day in a long-term care setting. It requires ongoing nursing judgment. Okay, so we've talked about the internal threats like infection and how to read the body's signals through vital signs. But your role as a nurse extends far beyond just observing and reacting to physiology. You are fundamentally the ultimate guardian of patient safety. This is a foundational right for every single individual under your care. The sobering reality is that healthcare environments, despite all the good intentions, carry inherent risks. Patient safety isn't just a checklist or policy. It's an unwavering, constant commitment to protecting vulnerable individuals when they entrust themselves to your care. Every nurse is a safety officer.
Absolutely. Safety is truly a foundational human need, right up there with basic physiological needs like food and water, as Maslow's hierarchy of needs shows us. It has to be a top priority in patient care. And the focus on patient safety really intensified nationally after that landmark report from the Institute of Medicine back in 2000 to Err is Human. It highlighted a shocking number of preventable deaths occurring annually due to medical errors, things like medication errors, mistaken patient identity, issues with restraints, falls, wrong site surgeries.
That report was a huge wake-up call. It led to a renewed focus on creating a culture of safety within healthcare organizations. Regulatory bodies like the Joint Commission also play a big role. They have initiatives like Zero Harm in Healthcare and publish annual national patient safety goals based on adverse event trends, constantly pushing facilities to improve.
So what does a culture of safety actually look like in practice? What does it mean for a nurse working in that environment?
It's about creating an environment where safety is truly valued above competing goals like speed or efficiency. It has three key components. First, a just culture. This means staff feel safe raising questions or concerns about safety and reporting safety events or near misses without fear of punitive action for honest human errors. It distinguishes clearly between unintentional errors, at-risk behaviors, and reckless behaviors, responding appropriately to each. Second, a reporting culture. This involves recognizing that errors are unfortunately inevitable in complex systems and actively encouraging everyone to speak up by reporting errors and near misses so the system can learn from them. And third, a learning culture. This is where the organization actively collects information from those reports, analyzes it to understand why errors happen, learns from both mistakes and successes, openly shares data, and uses the best available evidence to redesign processes and improve safety. It's about systemic improvement, not blaming individuals.
Many factors can influence a patient's safety, right? Their age, lifestyle choices, mobility issues, sensory problems, even their ability to communicate. So safety assessments are key.
Definitely. Your safety assessment needs to look at the whole picture. The person, their environment, and any specific risk factors they might have. During your nursing history, you'll ask about any previous falls or accidents, if they use assistive devices like walkers or canes, any history of drug or alcohol abuse, their family support system, and potential hazards in their home environment if they're going home. Your physical examination will assess their mobility status, gait, balance, their ability to communicate effectively, their level of awareness and orientation, any sensory deficits like poor vision or hearing, and you'll actively look for potential safety hazards in their immediate environment. You also need to be alert for signs of domestic violence or neglect.
Let's talk specifically about one of the biggest safety challenges, falls. They are incredibly common and can be devastating, especially for older adults. Preventing falls is a huge part of a nurse's job.
The statistics are truly sobering. Around 1 in 3 people over the age of 65 falls each year in the community. Millions of older adults end up in the emergency room for fall injuries annually, and hundreds of thousands are hospitalized, often for serious injuries like head trauma or hip fractures.
And the consequences go beyond just the physical injury, don't they?
Absolutely. There's the physical trauma, which can range from bruises to life-altering fractures of the hip, pelvis, or spine, or serious head injuries like concussions. But there's also a significant psychological impact. Many people develop a fear of falling after just one fall. This fear can lead them to become less active, trying to avoid situations where they might fall. But ironically, this decreased activity leads to muscle weakness and poorer balance, which actually increases their risk of falling again. It's a vicious cycle.
What are some common symptoms of a concussion if a fall does result in a head injury?
Concussion symptoms can be physical, cognitive, or emotional. Physical symptoms might include headache, nausea or vomiting, balance problems, or dizziness. Cognitive symptoms could be feeling mentally foggy, having difficulty concentrating or remembering. Emotional symptoms might include irritability, nervousness, or sadness. Sleep patterns can also be disturbed, feeling drowsy, or having trouble falling asleep, or sleeping more or less than usual.
What conditions or factors put patients, especially hospitalized ones, at a higher risk for falls?
Several key factors increase fall risk in the hospital setting. A history of falls, especially within the last few months, is a major predictor. Mobility problems requiring assistive devices, taking multiple medications, particularly those that cause sedation, confusion, impaired balance, or orthostatic hypotension, a drop in blood pressure upon standing. Also altered mental status, delirium, dementia, psychosis, incontinence leading to rushing to the bathroom, being tethered to equipment like IV poles or Foley catheters, impaired vision, and that orthostatic hypotension we mentioned. Certain conditions like lower body weakness or vitamin D deficiency also contribute.
So, knowing the risks, what are the core prevention strategies? What are universal fall precautions?
Universal fall precautions are basic safety measures applied to all patients, regardless of their individual risk level. These include familiarizing the patient with their environment, showing them how to use the call light, and ensuring it's always within reach, along with personal possessions, making sure there are sturdy handrails available, keeping the bed in the lowest position except when providing direct care or transferring, ensuring bed brakes are locked and wheelchair brakes are locked when stationary, providing no-slip footwear, using night lights or supplemental lighting, especially at night, keeping floors clean, dry, and free of clutter, and using safe patient handling techniques and equipment.
Facilities usually have specific policies too, right?
Yes. Most facilities use a standardized fall risk assessment screening tool upon admission and at regular intervals. Based on the score, specific interventions might be implemented, like placing signs at the bedside or on the door, using special colored wristbands, and defining parameters for reassessment. Hourly rounding by nursing staff has also been shown to significantly increase patient safety and satisfaction. It involves proactively checking on patients regularly, addressing needs like toileting, positioning, pain management, and ensuring the environment is safe, often using prompts like the 4 Ps, pain, position, potty, possessions. Simply asking, "Is there anything I can do for you?" goes a long way.
What about tools or programs specifically for fall prevention?
There are many. The CDC has the STEADY program, stopping elderly accidents, deaths, and injuries, primarily for community settings, using screening questions to identify risk. There are devices like bed alarms or chair alarms, though their effectiveness is debated and they can sometimes increase agitation. Within hospitals, many use targeted solutions tools, implement specific falls toolkits, conduct falls prevention training for staff, and perform fall scene investigations after a fall occurs to understand exactly what happened and how to prevent recurrence.
We touched on restraints earlier. Can you quickly reiterate the serious physiological hazards associated with their use?
It's crucial to remember that restraints, while sometimes used with the intention of preventing falls or injury, actually carry significant risks themselves. They can increase the possibility of serious injury if the patient falls while restrained. They contribute to skin breakdown, muscle weakness and contractures, incontinence, depression, delirium, anxiety, aspiration if the patient vomits, respiratory difficulties, and even, tragically, death from strangulation or other complications. Their use must be a carefully considered last resort, with strict protocols and monitoring. Given all these risks, there's a simple mental checklist every nurse should run through every single time they leave a patient's bedside. This is non-negotiable for basic safety.
Okay, what's on that checklist?
Is the bed in its lowest position? Is the bed position safe for the patient? For example, head to bed elevation if needed. Are the bed controls functioning correctly and electrically safe? Is the call light functioning and within the patient's reach? Are the appropriate side rails raised if indicated based on assessment and policy? Not always all 4. And are the wheels or casters on the bed and any nearby equipment locked?
That seems like a solid routine check. But despite best efforts, procedure-related accidents and medical errors can still happen.
Unfortunately, yes. Errors can occur during various procedures, administering medications or IV solutions, transferring patients, changing dressings, applying external heat. The list goes on. And the national impacts, as highlighted by reports, suggest that preventable medical errors are a major cause of harm and even death. This just underscores why meticulous attention to detail, following procedures correctly, and adhering to safety protocols are absolutely paramount in every single thing you do as a nurse.
When things do go wrong or almost go wrong, reporting is crucial. This brings us to event reporting. It might seem bureaucratic, but these reports are vital for that learning culture we talked about. It's not about blame, it's about making the system safer.
Exactly. Safety event reports, often called incident reports, are completed after any accident or incident that compromises safety occurs in a healthcare facility. The report objectively describes the circumstances of the event, the patient's response, including assessment findings and vital signs, and any examination or treatment conducted afterward. It should be completed immediately by the nurse who witnessed or found the incident, and this is crucial. The incident report is an internal document for quality improvement and risk management. It is not part of the patient's permanent medical record, and you should never mention in the patient's chart that an incident report was filed.
It's helpful to understand the different types of events that get reported. Can you clarify the difference between a near miss, a patient safety event, a sentinel event, and a never event?
Sure. A near miss, according to the World Health Organization, is a potential error or event or circumstance that could have caused harm but was caught or avoided before it reached the patient. These are golden opportunities for learning because you can fix the problem before anyone gets hurt. A patient safety event is an unexpected event or circumstance that did occur but resulted in no injury to the patient, still needs reporting and investigation. A sentinel event, as defined by the Joint Commission, is a patient safety event that results in severe physical or psychological harm, think death, permanent harm, severe temporary harm requiring intervention to sustain life, or an event that poses a risk of such harm. Sentinel events mandate reporting and a thorough investigation called a root cause analysis, RCA. And never. Events are a specific list of serious adverse events that are clearly identifiable, measurable, usually preventable, and result in death or significant disability. Examples include wrong site surgery, leaving a foreign object in a patient after surgery, or death disability from a medication error. They're called never events because they should simply never happen. Regulatory bodies like CMS, Medicare, Medicaid, often won't reimburse hospitals for costs associated with these events, and they're usually publicly reported. When a serious event like a sentinel or never event occurs, a root cause analysis, RCA, is conducted. This isn't about finding someone to blame. It's a deep dive review process to figure out why the error happened. Was it primarily human error, or were there underlying systems failures, like poor communication protocols, inadequate staffing, faulty equipment? The goal is to identify the root causes and establish a corrective action plan to prevent it from happening again.
There can be barriers to reporting, of course, fear of blame, lack of time, unclear policies, but overcoming these is essential for creating that safe learning culture. Let's finish this section with one of the most critical safety checks a nurse performs daily: preventing medication errors using the rights of medication administration.
Absolutely. This is a cornerstone of safe nursing practice. The standard of care requires nurses to perform 3 checks of the medication against the Medication Administration Record, MAR, along with verifying the 5 rights, and often more, depending on the facility, of medication administration before giving any drug.
And those 5 core rights are:
1. Right patient. Always use at least 2 unique patient identifiers. Name and date of birth are common, or name and medical record number, never just the room number. 2. Right medication. Check the medication label against the MAR carefully. Be aware of look-alike, sound-alike drugs. 3. Right dose. Calculate carefully. Double-check calculations, especially for high-alert meds, and use appropriate measuring devices. 4. Right route. Ensure the medication is given via the prescribed route: oral, 5E, IM, topical, etc. 5. Right time. Administer the medication at the correct time, adhering to the prescribed frequency and any specific timing requirements, like with meals or on an empty stomach. Mastering these checks and rights is absolutely non-negotiable for preventing potentially devastating medication errors. Many facilities also use strategies like do not use lists for dangerous abbreviations, high alert medication protocols, and technology like barcode scanning to add further layers of safety.
Okay, so you've got a handle on the science of infection, the framework of the nursing process, reading vital signs, and the critical importance of safety protocols. But none of that truly matters if you can't connect with your patients on a human level. This is where the art of nursing, the communication piece, really comes into play.
You've hit on something crucial. Communication is the fundamental process of transferring information, thoughts, and feelings between people. It can be verbal, nonverbal, written, or electronic. In nursing, effective communication is absolutely basic. It's the foundation upon which you build therapeutic relationships, those caring, kind, respectful, and trusting connections you establish with your patients and their families.
Why is it so important?
Well, good communication fosters understanding, which is essential for assessing needs and providing care. It reduces conflict and misunderstandings. It enhances clinical learning for you and teaching for the patient. It strengthens programs and policies when teams communicate well. Ultimately, it provides a strong foundation for safe practice. Clear communication prevents errors. It forces clarification of thoughts and intentions, and it can even help manage behavior by clearly stating expectations.
So how do we communicate as nurses? What are the different modes?
We primarily use 4 modes. Verbal communication involves the spoken or written word language. Nonverbal communication is incredibly powerful. It includes body language, facial expressions, touch, eye contact, posture, gait, gestures, as well as physical appearance, grooming, sounds like sighs or tone of voice, and even silence. Often, nonverbal cues convey more meaning than words. Then there's electronic communication, like email, text messaging, or using electronic health records. This requires extreme care regarding patient privacy and confidentiality, following HIPAA guidelines and agency policies. Using social media inappropriately can have serious professional consequences. And written communication, which includes documentation in the patient record, requires clarity, accuracy, and conciseness. Various communication models exist, but at their core, they all involve a sender, a message, a channel, and a receiver. The key element for effective communication is feedback, the receiver's response, which indicates whether the message was received, understood, and interpreted correctly. Noise, either literal or figurative, like pain or anxiety, can interfere with the process.
What kinds of things influence how effectively we communicate?
Many factors come into play. The patient's developmental level, you communicate differently with a child versus an adult. Gender can sometimes influence communication styles. Sociocultural differences, language, cultural norms about eye contact or touch. Roles and responsibilities can create power dynamics. Space and territoriality, respecting personal space. The individual's physical, mental, and emotional state, pain, anxiety, or confusion can be huge barriers. Personal values and beliefs. And the environment itself, a noisy, chaotic environment, hinders communication.
And our own communication style matters too, right? How we tend to interact.
Absolutely. We often talk about four main styles. Passive. People using this style tend to avoid conflict, say nothing, or just agree to keep the peace, often letting their own rights be violated. Assertive. This is the goal for professional communication. It involves being honest, direct, and clear, standing up for your own rights and needs while respecting the rights and needs of others. Assertive communicators use I statements, ask for help when needed, can give and accept compliments, admit mistakes, and take responsibility. They project confidence and openness. Aggressive. This style involves expressing feelings and opinions in a way that violates the rights of others, often verbally or even physically abusive, creating tension and anger focused on winning at all costs. Passive-aggressive. This is a bit more subtle. The person appears passive on the surface but expresses their anger or resentment indirectly, perhaps through procrastination, sarcasm, or stubbornness.
Assertiveness sounds like the sweet spot for nurses.
It really is. It allows you to advocate effectively for your patients and yourself and collaborate respectfully with the team. There's also a specific therapeutic communication technique called motivational interviewing, often remembered by the acronym ORS.
ORs.
Yes. O for asking open-ended questions that encourage elaboration. A for affirmations, recognizing the patient's strengths and efforts. R for reflective listening, showing you understand their perspective by paraphrasing or reflecting feelings. And S for summarizing, pulling together key points of the conversation. It's a very client-centered approach to help patients explore their own motivations for making health changes.
At the very heart of nursing is the therapeutic relationship. You mentioned communication builds this. Can you expand on that?
The therapeutic relationship is that helping relationship based on care, kindness, respect, and trust between the nurse and the patient. It doesn't just happen automatically. You have to consciously build that trust and rapport. It has specific characteristics. There's an unequal sharing of information. The focus is always on the patient's needs and experiences. The nurse is the helper, but the relationship shouldn't be paternalistic or authoritarian. It's a partnership. It's dynamic, purposeful, aimed at patient goals, usually time-limited, and the nurse is professionally accountable for maintaining boundaries and ethical conduct.
Are there theories that guide this?
Yes. Theorists like Gene Watson emphasize the importance of human caring, authenticity, protecting human dignity, and practicing loving kindness within the relationship. Hildegard described phases the relationship typically moves through. 1. Orientation phase. Introductions, establishing trust, defining roles, agreeing on a contract or goals for the relationship. 2. Identification working phase. This is the active phase where the nurse and patient work together towards the goals. The nurse uses interventions like assistance, counseling, and teaching. Problems are identified and explored. Trust deepens. 3. Termination resolution phase. This occurs when the goals are met, the patient is discharged, or the therapeutic relationship otherwise ends. It involves summarizing accomplishments and acknowledging the end of the relationship.
So how can a new nurse get better at this? What are the keys to mastering effective communication?
It starts with cultivating positive dispositional traits, being warm and friendly, open and respectful, empathetic, understanding the patient's feelings, honest and trustworthy, genuinely caring, and demonstrating competence. Patients pick up on these qualities. Then there are practical rapport builders, having specific objectives for the interaction, ensuring a comfortable and private environment, maintaining confidentiality, focusing on the patient rather than just the tasks, utilizing your nursing observations, and pacing the interaction appropriately.
What about actual conversation skills?
Good conversation skills involve controlling your tone of voice, being knowledgeable about the topic but flexible, speaking clearly and concisely, avoiding jargon or terms that might be misinterpreted, being truthful without giving false reassurance or resorting to cliches, keeping an open mind and taking advantage of available opportunities for communication. And maybe most importantly, listening skills. This means truly hearing and understanding. Sit with the patient if possible, be alert but relaxed, maintain natural eye contact if culturally appropriate, use appropriate facial expressions and body gestures that show interest, think before you respond, don't pretend to listen, listen for underlying themes in what the patient is saying, and learn to use silence, therapeutic touch, and humor appropriately.
Interviewing techniques are also tools in the toolbox.
Yes, knowing when to use different types of questions. Open-ended questions to encourage sharing, closed questions for specific information, validating questions to confirm understanding, clarifying questions to ensure you grasp the meaning, reflective questions to echo feelings, sequencing questions to understand timing, and directing questions to obtain more information about a topic.
Despite our best efforts, communication can break down. What are some common barriers or blocks we should be aware of?
Many things can get in the way. Common barriers include failing to perceive the patient as a unique human being, simply failing to listen attentively, using non-therapeutic comments or questions, like cliches, everything will be all right, asking why, questions which can sound accusatory, probing too much, language differences, cultural misunderstandings, physical impairments like speech or hearing difficulties, developmental or cognitive disorders affecting comprehension, side effects of medications, influence of recreational drugs, high levels of distress or pain, and unfavorable environmental factors like noise or lack of privacy.
What about specific things nurses might say or do that block communication?
Yes. Certain blocks include asking leading questions that suggest the desired answer, giving unsolicited personal advice, making judgmental comments, changing the subject inappropriately, offering false reassurance or false hope, and engaging in gossip or rumors. We also need to be aware of disruptive interpersonal behaviors within the healthcare team. Things like incivility, bullying, horizontal violence, nurse-to-nurse aggression, or negative communication patterns between nurses and physicians. These toxic behaviors severely undermine teamwork, safety, and morale.
To improve communication between healthcare professionals, especially during critical handoffs, there's a standardized tool often used, right? SBR.
Yes. SBR is a widely adopted communication tool designed for clarity and efficiency. It stands for situation. Briefly state the problem. What is going on with the patient right now? Background. Provide brief, relevant context what led up to this situation. Assessment. State what you think the problem is, your assessment of the situation. Recommendation. State what you need or recommend. What action do you think is needed? Using SBR provides a predictable structure for crucial conversations, ensuring essential information is conveyed clearly and concisely, reducing the risk of errors due to miscommunication. So communication isn't just about sharing information back and forth. It's fundamentally about empowering your patients. And this leads us directly into the crucial role of patient education. This is where you truly enable patients to understand and take control of their own health. The goals of patient education are really clear and tie back to the overall goals of nursing, enabling the patient to maintain and promote their health, prevent illness, restore health after illness or injury, and facilitate coping with impaired function or chronic conditions. There are even standards around this. For example, patients should understand how to prevent surgical site infections before they have a procedure.
To be an effective teacher, you need to understand how people learn, right? Because not everyone learns the same way. As a nurse, you need to be flexible. What are the main learning domains we consider?
That's right. We generally categorize learning into three main domains. Cognitive learning. This involves intellectual skills and behaviors, things like acquiring knowledge, understanding concepts, comprehension, applying information, analyzing situations, synthesizing ideas, and evaluating. Basically, the thinking part of learning. For example, a patient learning about their new medication, what it does, when to take it, potential side effects. Affective learning. This domain deals with changes in attitudes, values, feelings, beliefs, and interests. It's about the emotional response to learning and its integration into the person's value system. For instance, a patient coming to accept their chronic diagnosis and becoming motivated to manage it effectively. Psychomotor learning. This involves acquiring physical skills that require integration of mental and muscular activity. It's learning by doing, involving perception, coordination, and manipulation. Examples include a patient learning how to self-inject insulin, change a dressing, or use an inhaler correctly. Effective patient education often involves strategies that address all three domains.
A huge challenge in patient education, though, is health literacy. Can you explain what that means and why it's so important?
Health literacy is a critical concept. It refers to the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions for themselves. It's not just about reading ability. It includes writing, numeracy, understanding numbers like dosages or risks, listening, speaking, and having some conceptual knowledge about health and the body. Low health literacy is incredibly common and is a major barrier to effective self-management and good health outcomes.
So what's the nurse's role here?
Your role is crucial in bridging this gap.
Yeah.
You need to assess for potential health literacy challenges and adapt your communication and teaching strategies accordingly. National organizations like the National Patient Safety Foundation, Healthy People Initiatives, and the Joint Commission all emphasize the importance of improving health literacy.
Is there a good technique for checking understanding, especially when you suspect low health literacy?
Yes, the teach-back method is considered a best practice. Instead of asking a closed-ended question like, "Do you understand?" which usually gets a simple yes, regardless of actual comprehension, you ask the patient to explain the information back to you in their own words.
You might say things like, we've gone over a lot of information. Can you tell me in your own words, what is the main problem we talked about? Or, what are the most important things you need to do when you go home? Or, why is it important for you to take this medication? This immediately shows you what they've grasped and where the gaps are, allowing you to clarify. It's also vital to use plain language, avoid medical jargon, and aim for about a 6th grade reading level in written materials. There's also a helpful acronym, TEACH, to guide patient education interactions. Tune into the patient. What are their needs, concerns, readiness to learn? Edit patient information, simplify it. Focus on key points, use visuals. Act on every teaching moment. Integrate education into routine care. Clarify, often use teach back. Check for understanding frequently. Honor the patient as a partner in the education process. Involve them in setting goals and making decisions.
What other factors can affect a patient's ability to learn, and how do we adapt our teaching?
Many factors create barriers. Besides health literacy, consider the patient's age and developmental level, their family support system and financial resources, cultural influences and beliefs about health, language deficits, their comfort level, pain, fatigue, or anxiety severely impair learning, their underlying cognitive ability, any sensory impairments affecting communication. Also, the patient's past experiences with healthcare can influence their trust and willingness to learn. Current stressors like role responsibilities or anxiety, and sometimes their personal values and beliefs might conflict with recommended health behaviors, linking back to the health belief model.
How do you approach teaching different age groups, like adults or older adults?
Adult learners are typically independent, bring a wealth of life experience to the table, are often motivated to learn when they perceive a need related to their developmental stage or social role, and prefer learning that is practical and immediately useful. For older adults, it's often helpful to allow extra time for processing information. Keep teaching sessions short to avoid fatigue, accommodate any sensory deficits, like using large print or speaking clearly, minimize distractions, and try to relate new information to familiar activities or past experiences. Patience and respect are key.
What exactly should we be teaching patients?
It depends entirely on their situation, but generally you'll teach about their illness or injury, what's happening, symptoms, what helps, prevention, their treatment plan, medications, procedures, therapies, compliance, and crucially, health promotion, how to achieve optimal wellness across all dimensions: physical, emotional, spiritual, intellectual, environmental, sociocultural.
What are some common teaching strategies?
You need a variety of strategies to cater to different learning styles, often simplified as VAK, visual, auditory, kinesthetic, role modeling, demonstrating behaviors, lecture for foundational info, often combined with discussion, group or one-on-one, demonstration, showing how to do a skill, discovery, problem-solving scenarios, and role-playing can all be effective. You'll also use various instructional materials, actual medical equipment, anatomical models, multimedia presentations, written brochures at appropriate literacy levels, digital media, reliable websites. Remember, cultural competence in keeping materials accessible, often at that 6th grade level.
And finally, how do you know if the teaching actually worked? How do you evaluate learning?
Evaluation is essential to see if the patient achieved the learning objectives. You need to assess all 3 domains if applicable. For the cognitive domain, you can ask questions, have them list steps, or explain concepts back to you. Teach back. For the affective domain, observe their behavior, listen to their comments about values or motivation. For the psychomotor domain, the gold standard is return demonstration, having the patient actually perform the skill while you observe. Remember to ask how and why. Questions to assess deeper understanding and avoid just asking, do you understand? And of course, thorough documentation of the entire teaching process, the need, the plan, what was taught, materials used, and the evaluation of learning is crucial.
Okay, let's shift to something that might seem very basic, but is profoundly important for a patient's health, their dignity, and just their overall well-being: hygiene and self-care. It's also an incredible opportunity for nurses to connect with patients and perform assessments.
You're absolutely right. Daily hygiene is far more than just getting clean. It's a fundamental aspect of nursing care and offers invaluable opportunities. When you're assisting a patient with bathing or oral care, you're performing a head-to-toe skin assessment, observing mobility, noting cognitive status, and building therapeutic rapport through touch and conversation. Key areas for attention include the skin, our largest organ. You'll assess its cleanliness, color, temperature, turgor, elasticity, moisture level, sensation, vascularity, and look for any lesions or breakdown. Use good lighting, compare sides of the body, and use standard terminology to describe findings. You'll also look at hair. Changes can indicate nutritional status or other issues. Nails, need to be kept trimmed and clean to prevent infection, and the oral cavity. Good oral hygiene is linked to overall health, preventing infections like pneumonia. Inspect their lips, gums, teeth or dentures, tongue, and palate. Perineal and vaginal areas require careful attention as they are prone to bacterial growth. And special care is needed for the eyes, ears, and nose, especially in patients who are unconscious, immobile, or have tubes like NG tubes or nasal oxygen cannulas, as these areas are prone to irritation or breakdown. Feet are also critical, especially in patients with diabetes or poor circulation, where poor hygiene can quickly lead to serious infections, ulcers, and even amputation. Patient education about foot care is key for these individuals.
What factors influence a person's personal hygiene practices? It seems like it would vary a lot.
It really does. Culture plays a big role. Different cultures have different norms about bathing frequency, acceptable body odor, etc. Spiritual practices might involve specific ceremonial washings. Socioeconomic class can impact access to facilities, soap, clean water, or toiletries. Developmental level matters. Infants and young children rely on caregivers. Adolescents might become very preoccupied with hygiene, while older adults might bathe less frequently due to dry skin or mobility issues. A person's health state is a major factor. Disease, surgery, or injury can significantly limit their ability to perform self-care. And of course, personal preferences. People have established routines and product preferences that should be respected whenever possible.
When providing hygiene care, especially for intimate areas, maintaining respect is paramount.
Absolutely non-negotiable. Always perform hand hygiene before and after care. Ensure patient dignity and privacy, close curtains, drape appropriately, only expose the area being worked on. Ask permission and gain consent before touching. Communicate clearly what you're about to do. Use respectful and professional touch. Maintain neutral facial expressions. Be respectful of all body types and conditions. We can apply the nursing process to hygienic care just like any other area. 1. Assessment. Collect subjective data. Ask the patient about their usual routine. Any problems like itching, burning, pain, what helps. Collect objective data. Perform that thorough examination of the skin, oral cavity, hair, nails, etc. Data analysis is crucial here to accurately identify problems.
Nursing diagnosis, based on that data.
Right. You might formulate diagnoses like bathing self-care deficit related to postoperative weakness, or impaired oral mucous membrane related to dehydration and mouth breathing, or even risk for impaired skin integrity related to incontinence and immobility, or wellness diagnoses like readiness for enhanced self-care. 3. Planning interventions. Based on the assessment and diagnosis, you plan specific interventions. Consider the patient's ability to participate. Can they have a full shower, a tub bath, or do they need a bed bath? What assistance level do they need? You need to factor in challenges like dementia, mobility limitations from stroke or amputation, or difficulties related to increased BMI, like reaching areas or skin fold care.
4. Interventions. This often involves scheduled care throughout the day.
Yes. Nurses typically provide or assist with early morning care, toileting, face, hands wash, mouth care before breakfast, morning care or AM care. Usually after breakfast, bathing, back massage, skin care, hair care, dressing, positioning, linen change. Afternoon care, tidying up, toileting, repositioning. Hour of sleep care or HS care, preparing for bed toileting, washing, oral care, back massage, ensuring comfort and safety. And as needed, or PRN care, like changing soiled linens due to incontinence, providing oral care more frequently if indicated, helping after spills.
You've mentioned back massage and bathing. What are the real purposes behind these seemingly routine tasks?
They have significant therapeutic benefits. A back massage can relieve muscle tension, promote relaxation and sleep, improve circulation, decrease pain and anxiety, provide an opportunity to assess the skin on the back, and offer comfort through therapeutic touch. Bathing does more than cleanse. It conditions the skin, relaxes the patient, promotes circulation through warmth and friction, provides gentle musculoskeletal exercise, can stimulate deeper respirations, promotes overall comfort, provides sensory input, improves self-image and morale, and offers a prime opportunity to strengthen the nurse-patient relationship through communication and care.
When providing care like a bed bath, privacy is key.
Absolutely. Provide all necessary articles beforehand. Ensure privacy, close curtains, doors. Use a bath blanket and only expose the part of the body being washed at that moment. Place toiletries conveniently. Assist as needed, but encourage as much self-participation as the patient is capable of to promote independence and dignity. Specific care interventions include thorough oral hygiene, brushing, flossing, denture care, mouth moisturizing, avoiding high-alcohol mouthwashes, taking special precautions for unconscious patients, careful eye care, cleaning inner to outer canthus, using artificial tears if needed, caring for glass contacts, ear and nose care, cleaning external ear gently, managing hearing aids, ensuring nasal passages are clear, especially with tubes, hair care, shampooing if possible, grooming, managing infestations like lice if necessary, beard mustache care, nail and foot care, assessing, cleaning, trimming if appropriate and not contraindicated, massaging feet, providing specific diabetic foot care education, and perineal vaginal care, performing respectfully and matter-of-factly, cleansing gently, allowing self-care if possible.
And finally, 5, evaluation for hygiene care.
Yes, you evaluate if the patient achieved the desired outcomes. Did their participation in self-care increase? Were interfering factors like pain or weakness eliminated or reduced? Is the patient compensating effectively for limitations? Have skin problems improved? Can they manage their prescribed hygiene regimen independently or with appropriate support? It's about ensuring their hygiene needs are met effectively and respectfully. So we've really covered a vast landscape today, haven't we? From those microscopic battles in infection control, through the foundational framework of the nursing process, reading the body's story and vital signs, the unwavering commitment to patient safety, and those crucial human elements of communication, patient education, and even personal hygiene. It's vital to remember how all these threads weave together. They aren't separate subjects. They form the rich, interconnected tapestry of holistic nursing care.
And for you, our listeners, prospective nursing students, you're embarking on a journey that will absolutely challenge you, it will inspire you, and most importantly, it will allow you to make such a profound difference in people's lives. These building blocks we've discussed today, they aren't just abstract concepts from a book. They're the actual tools you will use every single day to empower your patients, to protect them from harm, and to help them heal and cope. Understanding this comprehensive, integrated approach right from day one truly sets you up for success in your studies and your future practice.
As you move forward into your studies and eventually into practice, I encourage you to always ask yourself this. Beyond the immediate task I'm performing, how does my action today contribute to this patient's holistic well-being? How does it contribute to a safer healthcare environment for everyone? And maybe we'd reflect on this. What stood out to you today is the most surprising connection between these seemingly different yet vital areas of nursing practice we've discussed. Thinking about those connections is key to developing strong clinical judgment.
Keep exploring, keep asking questions, and definitely keep that curiosity burning. We really hope this deep dive has given you a valuable head start and a clearer picture of the incredible path you're taking towards becoming a nurse. Until next time, stay informed, stay engaged, and keep diving deep.